In this PowerPoint, we're going to be talking about cellular regulation. When we talk about the concept of cellular regulation, we are talking about functions carried out within the cells in order to maintain homeostasis. The cell is the basic unit of life and the working unit of all living systems. Although life begins with just one single cell, by adulthood we have about 75 trillion cells in our body. Our cells function differently depending on location, but cellular reproduction and growth are regulated by the body. Alterations in this cellular regulation can have devastating consequences for body tissues and bodily functions. In general, three factors influence cancer development. 1. Exposure to carcinogens. 2. Genetic predisposition. And 3. Our immune function. We all have things called oncogenes in our cellular makeup. They are not abnormal. They are turned on or off depending on when cells need to divide. When a normal cell is exposed to a carcinogen, the normal cell's DNA can be damaged or mutated. Suppressor cells that turn off the oncogenes are damaged, and so the oncogenes are overexpressed and can cause cells to change into cancer cells, and then uncontrolled cell division occurs. Another factor to consider when talking about the development of cancer is oxidative stress. Oxidative stress is the body's physiological response to both external and internal stress factors. Oxidative stress occurs when the body is unable to adequately manage or neutralize molecules called free radicals. Different things can cause production of free radicals. Free radicals are produced as end products of food breakdown and also may be produced when the body is exposed to certain environmental toxins, such as radiation or tobacco smoke. Psychosocial factors such as anxiety and depression may also cause oxidative stress. The cellular damage caused by oxidative stress is linked to several disorders, including cancer. When cancer develops, we have an abnormal and rapid growth of cells that may invade surrounding body tissues and spread to other sites. Many factors have been implicated in causing cancer: viruses, bacteria, chemicals, genetic factors, diet, and hormones, to name a few. These deviant cells grow aggressively, and they don't respond to the body's homeostatic controls. Cancer cells refuse to die, and they can even grow their own new blood vessels that allow the tumors to grow unchecked. Cancer is a disruptive and life-threatening process that affects the whole individual as well as their significant others. Nursing care of the cancer patient needs to be holistic and comprehensive. Cancer care involves early detection, treatment, supportive care, long-term follow-up care, prevention, and for some, end-of-life care. Since lung cancer is the leading cause of death, and colon cancer is the third leading cause of death from cancer for both men and women, these are the two types that we will discuss. We will talk a little bit about the etiology, signs and symptoms, and diagnostic tests for both lung and colorectal cancer, and then we'll consider the interventions for both types together. But as before, we first want to look at some of the pediatric considerations in regard to cellular regulation. And when you look at this slide, you can see that a child's understanding of cancer is very dependent on their age. Infants and toddlers are unaware of the severity of the disease, and they deal with issues such as pain and separation from the parents. Preschoolers are beginning to understand the illness. They may think that they caused their illness, and they also may be confused about why the parent cannot make the illness go away. School-age children obviously understand their diagnosis, and they benefit from having opportunities to talk about their experiences. Adolescents also actually, on the other hand, find contact with others who've gone through their experience to be reassuring and supportive. A diagnosis of cancer can be devastating to the child and the family. Nurses caring for the child or adolescent with cancer must provide care that is family-centered. The needs of the parents and the siblings must also be considered in addition to the needs of the patient. While survivorship has increased and the mortality rates for childhood cancers have gone down drastically, there are sometimes short-term and or long-term effects of treatments. Examples of that would be impairment of bone growth, poor dental health, chronic pain, delayed puberty and sterility, impaired cognition, secondary cancers that sometimes develop, as well as long-term psychological stress. In regard to gerontologic considerations, you can see that 60% of new cancers occur in people over the age of 65, and 70% of deaths from cancer also occur in that age group. Again, it's those free radicals that accumulate over time, causing much damage as well as mutation. In older people, their response to treatment can be altered because of declining function. They have comorbidities and lots of medications that can lead to drug interactions. The adverse effects of treatment can be more severe for the older patient. Also, recovery of treatment is slower, and altered social and economic resources can impact the care. Sometimes access to care for the elderly is limited. We just need to be careful as nurses not to be too discriminatory or fatalistic in our attitudes for those older people that have cancer. In terms of racial considerations, we know that there has been substantial progress in cancer treatment, cancer screening, diagnosis and prevention over the past several decades. But addressing cancer health disparities, such as higher cancer death rates, less frequent use of proven screening tests, and higher rates of advanced cancer diagnosis in certain populations, is an area that hasn't kept pace with the other progress that's been made. These disparities are frequently seen in people from low socioeconomic groups, certain racial/ethnic populations, and those who live in geographically isolated areas. There are many different reasons for this. Some include people that in lower socioeconomic groups and geographically isolated areas simply may not have access to the screening and advanced health care that others have available. Minorities are often underrepresented in clinical trials, and so the genetic, dietary, and lifestyle factors that impact cellular regulation are not adequately studied. So just take a moment to read through the slide to see what some of these disparities are. So lung cancer, let's begin here. In the U.S., there are more than 224,000 new cases of lung cancer every year, and more than 158,000 deaths each year. The 5-year survival rate for lung cancer is only 14%. And while you can see on this slide that there are known carcinogens, out there in the environment, it truly is cigarette smoking that's the cause of 85% of lung cancer deaths. So this is a preventable cancer. It's the repeated exposure that causes chronic tissue irritation and inflammation. The more a person smokes and the longer the person smokes, the greater the risk. We have two basic types of lung cancer. We have small cell lung cancer and non-small cell lung cancer. With small cell lung cancer, it accounts for approximately 25% of the lung cancers that are diagnosed. They grow rapidly and spread early, which is why 40% of the patients have distant metastases by the time they finally go to the doctor with signs and symptoms. These are also the cancers that have paraneoplastic properties, and I'll come back to that term in a couple more slides. Non-small cell includes everything else. squamous, adenocarcinoma, and other large cell cancers. And they account for the other 75%, but they're all just lumped together into one big classification because they respond similarly to treatment. In terms of signs and symptoms, you know that in the early stages, lung cancer really has no dramatic signs or symptoms, again, which is why so many are diagnosed late. When symptoms start to appear, you know, it's because their lungs are being taken over and the breathing passages are being blocked. Lung cancer has both what we would call local and systemic effects. The local effects are those that surround the lung itself, like cough, excess mucus production, shortness of breath, hemoptysis, and chest pain. But there can also be systemic effects such as fever, anorexia, and malaise. So again, here's a slide that talks a little bit more about the multi-system effects of lung cancer and the paraneoplastic syndromes that occur, especially with small cell lung cancer. And these are caused by hormones or other substances like enzymes or cytokines that are secreted by the tumor cells. The symptoms occur remotely, which means far away from the tumor site. And the symptoms can affect almost any system, our endocrine system, our musculoskeletal system, cardiovascular, GI, renal. And if you can look at this slide a little bit more closely, there are examples up there. If the parathyroid hormone is secreted to excess, the patient will end up with hypercalcemia. They can also end up with hyperphosphatemia. If too much adrenocorticotropic hormone is secreted, they end up with Cushing syndrome. And on. You can take a look at that slide up on your computer so that it can be a little bit larger and you can see. When it comes to staging, there are several different ways to classify and stage the tumors. The American Joint Committee on Cancer developed this type of staging. It's the tumor, node, metastasis, TNM system, and they developed this in order to describe the general anatomic extent of cancers. The stages are useful to guide treatment and also for prognosis. Many different types of cancers are staged, and so you might be familiar with this specific TNM system. And what's up here on this slide is the staging criteria that's specific for lung cancer. In terms of diagnostic tests, it's usually the chest X-ray that provides the first evidence of lung cancer. We would want to obtain sputum, and it needs to be an early morning sputum in order to look for tumor cells. Sputum that's negative for any cancer cells does not rule out lung cancer. Cells or tissue can also be obtained by aspirating fluid from a pleural effusion or a percutaneous needle biopsy and lymph node biopsy. Those would be other ways. We could do a bronchoscopy, and that would allow visualization of the tumor. You could also obtain a biopsy specimen during the course of a bronchoscopy. You could also do a bronchial washing, which means we flush the area with normal saline in order to obtain cells for cytology. A CT, MRI, or PET scan would all give more detailed information and it will also help to locate any metastases that are already there. Labs, like a CBC, LFTs, or electrolytes, could also give evidence of metastases or also those paraneoplastic syndromes that we talked about earlier. PFTs, pulmonary function tests, as well as arterial blood gases, would evaluate more directly the lung function. So those are some of the diagnostic tests used in order to diagnose lung cancer. So now colorectal cancer. Colorectal cancer is a disease of Western culture because of our diet. When you have economically prosperous countries, people consume diets that are high in calories, high in meat proteins, and high in fats. And this type of diet is thought to increase the anaerobic bacteria in the gut. The bacteria convert bile acids to carcinogens. On the other hand, diets that are high in fruits, vegetables, folic acid, and calcium appear to reduce the risk of colorectal cancer. Nearly all of the colorectal cancers, up to 95%, are what are considered to be adenocarcinomas, that is, cancers that rise from the lining of the intestines. These cancers begin as polyps, which are growths on the internal surface of the bowel. Most tumors develop in the rectum and the sigmoid colon, although any portion of the colon may be affected. When colon cancer metastasizes, it commonly goes to the liver as well as the lungs, brain, bone, and adrenal glands. Risk factors for colorectal cancer are listed here. Increasing age is a risk factor. Also, a family history of colorectal cancer. There is a thing called Lynch syndrome. It's an inherited condition that increases your chance of colon cancer. Lynch syndrome is an autosomal dominant genetic condition. It's also called hereditary non-polyposis colorectal cancer. What a mouthful. They also experience cancers in other areas of the body, but about 3 out of every 100 colon cancers are caused by Lynch syndrome. And again, of course, if you've had a previous colon cancer, that places you at risk for developing it again. And polyps are considered to be precursors to that adenocarcinoma. Smoking, drinking, and obesity also contribute, as well as a history of inflammatory bowel disease. And again, I already mentioned the diet, our bad Western diet, that's a risk factor. In terms of development, colorectal cancer is a very slow-growing cancer. 5 to 15 years of growth may occur before manifestations develop, and that's why so many colon cancers are not found in the early stages. Only 39% are detected early, and as with lung cancer, this greatly affects the survival rate. Again, as with lung cancer, colon cancer often has no manifestations until it's advanced. Then the manifestations will depend on the location, type, and extent of the tumor. Early manifestations include a change in bowel habits, constipation, or diarrhea, number 1 and 2 on this slide. But they often aren't recognized as warning signs of colon cancer. It's usually number 3, rectal bleeding or blood in the stools, that prompts the patient to seek medical care. Obviously, if a tumor was making the lumen of the colon more narrow, you would end up with narrow stools. The bleeding that occurs leads to anemia. Later signs include abdominal tenderness, abdominal pain, unexplained weight loss, and even palpable abdominal or rectal masses. We can also stage colorectal cancer. This is a different type of staging than the TNM system. In this staging system, stage 0, the cancer is only in the inmost lining of the colon or rectum. Stage 1, cancer has not spread beyond the inner wall. Here we see it. Stage 2, cancer has spread into the muscle layer of the colon or the rectum. Stage 3, cancer has spread to 1 or more lymph nodes in the area. And stage 4, as with most of the staging systems, the cancer has now spread to other parts of the body. Diagnostic tests for colorectal cancer include fecal occult blood test. You'll also hear it called hemoccult or a guaiac of the stool. And this test will detect the microscopic blood that's in the stool. They just need a stool sample and then they place it on the slide. There's a hemoccult developing solution that's dropped onto the other side from the stool sample. And if it turns blue, that constitutes a positive test. This fecal occult blood test is recommended to be done yearly after age 50. Now your book mentions a double contrast barium enema every 5 years, but this would not usually be the test of choice. What's far more common is either a flexible sigmoidoscopy or a colonoscopy. A flex sig will detect 50 to 65% of colorectal cancers, but most doctors are going to recommend a colonoscopy. It is the definitive test for colorectal cancer. You can obtain tissue for biopsy. You can remove polyps if you find them during colonoscopy. And so flexible sigmoidoscopy is recommended every 5 years, whereas colonoscopy every 10. And again, it's because colon cancers are very slow growing. Now a CT and an MRI would show the same thing it does when we do them for lung cancer. It would show the existence of the mass, it would show the extent of the disease, and also location of distant metastases. A CBC would detect the anemia that is common, and then you have a CEA, carcinoembryonic antigen. It's a tumor marker that can be detected in the blood. But it can also be found in the blood of patients with other benign or malignant diseases, and interestingly enough, it's also found in the blood of smokers. In relation to colon cancer, it's used to estimate prognosis, it's used to monitor treatment, and it will also help to detect cancer reoccurrence if the values elevate after initial treatment. A normal CEA value should be less than 5. So this ends our brief overview of lung cancer and colon cancer, and we'll pick it up in class with treatment of the cancers.